Hello, my name is David Nutt. I'm a psychiatrist, psychopharmacologist from London, and past president of the ECNP. And today I'm going to talk to you about the classification system of currently used treatments in psychiatry and show you some of the approaches that the ECNP is taking to make more sense of it, to make it more useful to you and obviously to improve the way we treat patients. So let's look at the current system. And if you see the first slide, you see there are some confusing acronyms which are used. So we have SSRIs, SNRIs, NASAs, TCAs. What do these mean? Let me give you an example of the confusion. SSRI, I think everyone knows, stands for selective serotonin reuptake inhibitor. You might therefore work out what SNRI might mean. So what would you think? Well, when I ask this question to medical students, they say, of course, it's a selective noradrenaline reuptake inhibitor, which is the wrong answer. And the reason it's the wrong answer is because companies have decided to call SNRIs serotonin noradrenaline reuptake inhibitors. Now, this wasn't a decision made by an academic group. It was a decision made by a drug company. And it's caused confusion because people do not know, by and large, what an SNRI means. Let's look at another term, NASA. Now, some of you think that's to do with the US Space Agency, but it's also a term that's applied to antidepressants, particularly drugs like mirtazapine. What does NASA stand for? Well, it stands for either a noradrenaline and selective serotonin antagonist, or a noradrenaline, antihistamine, and selective serotonin antagonist, or it could actually stand for lots of other possible collections of words. And the answer is no one really knows what it means, and therefore it probably isn't a very useful term. Moving on to tricyclics, TCAs. Well, what does tricyclic tell us? Tricyclic is a description of the chemical structure. It actually confers no information whatsoever about the pharmacology of the drug. It doesn't even tell you it works for depression. Many drugs have tricyclic structure. Some benzodiazepines, some antihistamines, some antipsychotics, and of course some antidepressants. So it's a useless term for anyone other than a chemist, and even for them it has very limited utility. Another problem we have is that the WHO classification system, which is the one that currently determines how drugs are classified and therefore how drug side effects are collated, puts most of the drugs we use to treat depression in a category called other. And I think we all agree that that is a completely useless category. If most drugs are in a category called other, the classification system must, by definition, be flawed. And here is the current classification system of drugs for depression. They start off under what we call the nervous system, which is a good start. They do work on the brain. And then they're called psychoanaleptics. Now, I've been working in this field for 40 years, and I don't think I even knew what the term psychoanaleptic was until I started trying to reflect on the classification system a couple of years ago. So it's a term that has no value to almost anyone. And then within the psychoanaleptics, there are anti-dementia drugs, drugs for depression, psychostimulants, and combinations. And then we look at the antidepressant classification, and we see there are drugs which work on reuptake sites, there are drugs which are enzyme inhibitors, and then there's the other group, as I say, the largest group are the others. And they're a rich variety of different drugs. And we understand their pharmacology, and it seems to me that it would be sensible if a classification system actually classified them according to their pharmacology rather than simply say they're others. It's an outmoded and very unhelpful construct. So one approach that we've been exploring at the ECNP is a mechanistic approach. Look at drugs and see what sorts of mechanisms they have. And this to some extent accords with the WHO for some elements of it, in that We can break drugs down into enzyme inhibitors, reuptake inhibitors, receptor-acting drugs. And then there are some drugs which work on more than one of these processes. They may be both reuptake inhibitors and drugs which work on receptors. They may be enzyme inhibitors and drugs which block reuptake. So there are examples of what we call multimodal drugs that work across these two different modes of action. If we apply this approach, we can come up with a classification like this, where we can talk about drugs which work on single receptor systems or multiple receptor systems, uptake systems, single uptake systems or multiple uptake systems, and also work on more than one system, work both on, say, reuptake and also on receptors. And for each of those classes, we can look at single drugs or drugs which have multiple actions. So this is one slightly more rational and complete way of revising drugs. But even this isn't enough to properly convey all the known information about a drug, because that simply says what class it goes in. It doesn't actually say what it is. And what we've been trying to do, therefore, is come up with a more rational system. Here's one that you might use, for instance, for antipsychotics. You could say that some of them are receptor blockers, and some of them block dopamine D2 receptors selectively. They have little influence on other receptor systems. These are drugs like haloperidol, pimozide, amisulpride. And then there are other drugs which work on dopamine receptors, but also work on other receptors. And their interaction with the other receptors is often with a higher affinity than they have for the dopamine receptor, which means that in clinical practice, when you do what you have to do with a drug to treat schizophrenia or mania, you have to block dopamine receptors to get an effect. Inevitably, you're blocking other receptors. So in the case of drugs like olanzapine, quetiapine, clozapine, you're blocking 5-HT receptors, particularly 5-HT2A receptors. You're also blocking 2C receptors. In many cases, you're blocking histamine receptors and noradrenaline alpha-1 receptors and muscarinic receptors before you get to the key therapeutic effect of blocking the dopamine receptor. Then we have other kinds of antipsychotic drugs which are dopamine receptor partial agonists, like aripiprazole. And then we have drugs which are not much used, but which were popular before the advent of the modern antipsychotic drugs, which we call dopamine depleters, drugs like reserpine, oxypertine, and tetrabenazine, which are these days really only used for people with severe movement disorders like Huntington's chorea. So that's one approach, but over the last year, the ECNP has been working with other international organizations in neuropsychopharmacology, the American College of Neuropsychopharmacology, the Asian College, and also the International College, the CIMP, plus IUPHAR, International Union of Pharmacologists, to see if we could come up with an even better scheme. And that's really the conclusion we have come to in the last year or so, is that we can do better. And the way to do better is through a multi-axial classification system. And after several meetings over the last year or so, we've come up with this vision, which is a 5-axis classification system. You see axis 1, we talk about the class of drug and the subtype. Axis 2, the primary pharmacological targets. Axis 3 relates to the biological activity in animals and in humans, and this will look at effects on neurotransmitters, on endophenotypes, on brain circuits, on gene expression, on physiological parameters, and any other parameters that you can think of or where there is evidence that the drugs work. Axis 4 relates to the clinical effects of these drugs, both relating to the effects therapeutically and also to adverse effects or major side effects. And then axis 5 relates to the indications. And it's important to specify that indications are licensed indications. So these are what we call in the UK marketing authorization. So these are what the drug can be sold for by companies. And that's quite different from what the drug can be used for, because, of course, any doctor can use a drug for any indication he or she likes, provided they have a good rationale for doing so. So that's why we distinguish axis 4 and 5. We want people to think creatively and constructively about the use of different drugs without necessarily being tied to just the licensed indications. So let me give you a worked example. Let's look at a new antidepressant, agomelatine. So this we call a class of receptor-acting drug or a receptor agent. The subtype is determined by which receptors it works on. So it works on melatonin receptors, where it's an agonist, and 5-HT2C receptors, where it's an antagonist. So the name, primary pharmacological targets, we're going to call it something like a melatonergic serotonergic agent, or possibly a melatonergic 5-HT2C receptor agent. Some terminology like that. We've not finalized this yet because this is very much a work in progress, but this gives you a flavor of the way we're thinking. When we look at the neurobiological activity, we can see in animals that it enhances noradrenaline and dopamine in frontal cortex. In humans, it dampens down the brain circuits that are stress responsive in amygdala and prefrontal cortex. And when we look at the physiological responses, we see that it resets abnormal circadian rhythms in animals and humans. When we look at the clinical observations, we see it's effective in depression and anxiety. It has a low level of sexual side effects, but also, in rare cases, can elevate liver enzymes. And the indications at present are just for major depressive disorder, although these are limited to Europe, and at present there are also studies going on, phase 3 studies going on in generalized anxiety disorder. So that's an example, and I hope you can see now that that kind of example, that single table, conveys to you an enormous amount of useful information, much more than any other classification system that we have talked about today. And what we're planning to do now is explore whether people like you actually find this useful. And we have done field testing of this in the ECNP meetings, this one currently and also the one last year. We've done it at the World Federation and the EPA meeting. So we've done quite a comprehensive analysis of what users think. Over 1,200 people have responded to questionnaires either at meetings or online. And the feedback has been almost universally positive. People like the information presented this way. It helps them understand much better what drugs are doing and how to use them. So where are we going to here? Well, from here, what to watch out for? Well, the first thing to say is we're going to have a manuscript. It'll be published in February. It'll be published in the special edition of European Neuropsychopharmacology, which we're publishing to celebrate 25 years of the ECNP. Over the next 6 months, we're going to do a number of examples of existing compounds using this multi-axial analysis, and so we can build up a repertoire of understanding and practice effects. And eventually, we want to do all the 150 compounds which are out there. We've already met with journal editors, and journal editors are very interested. We want them to buy into this so that in future publications we'll talk about drugs using this multi-axial classification. And then, as we've done already at this meeting, and as we will do once that publication is out there, we'll begin a dialogue with other groups, patient groups, regulators, international groups, to see if we can get them to accept that this is a significant advance in terms of nomenclature. And I hope you feel so too. And if you do, feel free to write to me by email or to ECNP. Tell me what you think. Thank you. Bye-bye.